All right, so today's video is going to be part one for chapter 8 in your Pharmacology for Technicians textbook. So chapter 8 is drugs for central nervous system disorders. So it first starts out with discussing or giving you an idea of what seizures are. So seizures result from an excessive firing of a small number of neurons with spread to adjacent neurons. So there are conscious periods and loss of control over movements or distortion of the senses. A convulsion is an involuntary contraction or series of contractions of voluntary muscles. Sitting on a charger. Epilepsy. So epilepsy is actually a neurologic disorder that is characterized by sudden and recurring seizures. It involves disturbances of neuronal electrical activity that interfere with normal brain function. All epilepsy patients have seizures, but not all patients with seizures have epilepsy. So that's a difference. So just because someone has seizures, it doesn't necessarily mean that it is epilepsy. So factors which influence the firing of the neurons. So positively charged ions will increase the firing. Negatively charged ions inhibit the firing of the neurons. Glutamate, which is the excitatory neurotransmitter in our body, will also increase the firing. GABA, which is the inhibitory neurotransmitter, will decrease the firing. So there's many different causes of seizures. Alcohol or drug withdrawal, epilepsy, high fevers can trigger seizures. Both hypo and hyperglycemia, so low blood sugar, high blood sugar, infections, brain tumors, trauma, or head injuries. So on slide 7, it actually gives you an idea of what happens. It's a scan of a brain to show you what the different levels are with a partial seizure versus a generalized seizure. So simple partial seizures, twitching and sensory hallucinations with no loss of consciousness. Complex partial seizures, you can get a blank stare. You can get post-seizure amnesia with impaired consciousness. Partial seizures are localized in a specific hemisphere of the brain. So whereas generalized seizures involve a malfunction in both of the hemispheres of the brain. So partial is located in one specific area or one specific hemisphere of the brain, whereas generalized seizures involve both hemispheres of the brain. Tonic-clonic seizures cause muscle rigidity, followed by muscle jerks with shallow breathing, loss of bladder control, and excess salivation. Status epilepticus does involve tonic-clonic convulsions. High fever, lack of oxygen, with or without a loss of consciousness. Absent seizure is typically where you get the blank stare. You can get rotating eyes, uncontrolled facial movements, but no generalized convulsions. Myoclonic seizures, a sudden, massive, brief muscle jerks or non-massive, quick jerks of the arms, hands, legs, or feet, and consciousness is not lost. Atonic seizure is a sudden loss of muscle tone and consciousness. So, when we think of seizures, we typically think of patients, going to the ground and their whole body is seizing and usually loss of consciousness, but there's actually very different types of seizures. Anti-epileptic drug therapy. So the principles of treatment are based off of many different things. So initiate monotherapy at a low dose, so starting off on a low dose, and increase the doses gradually. Monitoring the plasma concentrations, because one of the things that happens with seizure medications is it's important to keep a consistent level of the drug in the blood at all times. If we go too high or too low, that can trigger seizures. Progress to combination therapy for severe cases. Periodically evaluate the continued need for therapy. Monitor for drug interactions. Watch for dispenses written on the prescription. So a lot of times anti-epileptic medications, especially with carbamazepine, if they're started on the generic version or if they're started on the brand Tegretol, because of the way that these drugs are absorbed in the body and dispensed in the body, excreted, and then the level within their plasma levels. These particular drugs, if a patient switches back and forth from a generic version to a brand version, it actually can have some effect on that. So the physicians will typically start them on either or, and that's what they're going to keep them on. So you're going to see it dispenses written prescriptions for those. And then, of course, these medications get dispensed with a medication guide. So anti-epileptic drug therapy, so mechanism of action. So you have sodium channel blockers, which block sodium in the fast sodium channels, which decreases inappropriate firing of the neurons. Your calcium channel blockers will block the calcium channels, which will also decrease the inappropriate firing of the neurons. GABA enhancers, so since GABA is an inhibitory neurotransmitter, it will also inhibit the firing of the neurons. So increasing the GABA is used as an anticonvulsant. Glutamate inhibitors, so glutamate is an excitatory neurotransmitter, which increases neuron firing. So if we use inhibitors for the glutamate, we're decreasing the amount of glutamate being produced in our body, and we decrease that, we will help or have a better opportunity to control the seizures. So different types of sodium channel blockers: carbamazepine, which is the one we just talked about. Tegretol is the brand name. Lacosamide, which is Vimpat, that's a controlled substance. Oxcarbazepine, which is trileptal. The carbamazepine is very good for tonic-clonic and also partial seizures, whereas the other two are typically just used for partial seizures. Phenytoin is used for tonic-clonic, partial, and status epilepticus. Phenytoin is the injectable version of phenytoin, so it's important to know the difference between Dilantin, which is phenytoin that's used in a non-injectable form, and fosphenytoin, which is the injectable version, and their dosing is not interchangeable, okay, between those two drugs. That is used for status epilepticus, and then the vigabatrin is also used for partial seizures. So fosphenytoin is dosed differently from other drugs. So on slide 13, instead of being based on weight, such as a milligram dose, fosphenytoin is dosed as a milligram of phenytoin equivalent. So 1 milligram of phenytoin equals 1 milligram of phenytoin equivalent, which is actually 1.5 milligrams of fosphenytoin. So you can see how 1 milligram of the phenytoin is comparable to 1.5 milligrams of the fosphenytoin, and so that's how those milligrams are not interchangeable. Technicians should be aware that milligram fosphenytoin are not the same milligram as phenytoin equivalents. Calcium channel blockers, these can be used for absent seizures, partial absent seizures, tonic-clonic, and then regular partial seizures. So valproic acid, which is Depakine, and divalproex, which is Depakote. Those are two separate drugs. So Depakote, Depakine, they are used widely for seizure disorders, but they can inhibit the hepatic function, and so it's important to that these patients have blood levels done consistently as well. So Depakine and Depakote are easily confused. It is hard to remember which is valproic acid, which is the Depakine, and which is divalproex, which is Depakote. You want to be very careful with Depakote ER and Depakote. The Depakote ER is a once daily, because it is an extended release version, and it is not bioequivalent to the Depakote twice a day. So Depakote by itself without ER is an immediate release, and that's typically dosed twice a day. The ER, or extended release version, is a once a day dose, and those two are not interchangeable. If a patient is switching between products, It's important to take that in consideration, but that's something that both the physician and the pharmacist are going to be monitoring. So GABA enhancers. So we have gabapentin or Neurontin. Gabapentin is widely used for many different things. Typically, the first line of why we use gabapentin is for seizures, but it's also been prescribed very heavily for depression and also for nerve pain. It is not a controlled substance, and it works really well. Phenobarbital, which is luminol, is a controlled substance. It's a C5. It is used for tonic-clonic seizures. It's also used for status epilepticus. This drug in particular does need monitoring of the drug levels inside the blood, and also to take in consideration that it is a controlled substance. Pregabalin, which is Lyrica, as a newer drug. They also, first line of why they're prescribing Lyrica is for seizures, but we have a lot of patients that have neuropathic pain that are caused by fibromyalgia, that type of thing where they have specific nerve pain. When you have specific nerve pain, narcotics are not going to work very well for that because it's not stopping the pain signal from the nerves, whereas Lyrica, luminol, and gabapentin will do that. Primidone is used for tonic-clonic seizures. It is also a controlled substance. And then the Gabatril is also used for partial seizures. So glutamate inhibitors. So again, glutamate is our excitatory neurotransmitter. So it increases the neuron firing. So we want to, if they want to block that or decrease the amount of glutamate that's in firing within our brains, they're going to give you a glutamate inhibitor. Those things are like Felbitol, Lamictal, which is lamotrigine. Other uses for Lamictal and lamotrigine also include depression and other mental health disorders. And Topiramax. So the one thing with Lamictal is watching out for a condition, watching out for a rash, because there's a particular syndrome that can be caused by this, which it can actually be life-threatening. Other anticonvulsants, so kind of one in its own thing is levetiracetam, which is Keppra. Keppra comes in both an injectable version and an oral tablet version and also a liquid version. This one is used to treat partial seizures. It does have some potential side effects of behavior changes, changes of thoughts of suicide and depression, so that's something that should be monitored as well. Characteristics, signs, so resting tremors, rigidity, echinacea. So pathology, or the pathophysiology. So when you have we've moved into Parkinson's. Okay, so Parkinson's disease. Characteristic signs of the Parkinson's disease is resting tremors. So someone that is just sitting still, sitting idle, and they're going to have the tremors. Okay, sometimes it's one hand, sometimes it's both hands, sometimes it's their legs. Rigidity. So loss of dopamine-producing neurons in a particular part of your brain. When you have an insufficient amount of dopamine, it's produced to counter the cholinergic activity. Cholinergic activity is the uncontrolled muscle movement. Predominance of cholinergic activity produces excessive motor nerve stimulation. So again, we have decreased the amount of dopamine for whatever reason in our body. Because of that insufficient amount, our cholinergic activity is then spiked, and then we get the uncontrolled excessive motor nerve stimulation. So drug therapy for Parkinson's disease. So improve the functional ability, the clinical status, and try to put the patients in a temporary remission. Unfortunately, it does not alter the disease process. There is no cure for Parkinson's disease. It is a progressive disease, and eventually it will get worse. Side effects may necessitate numerous medication changes. So there's a lot of different side effects associated with the medications for Parkinson's disease. And depending on how well the patients are tolerating those side effects, they may have to kind of bounce around from different medications until they find what works well. So carbidopa, levodopa, carbidopa, and your dopamine agonists. So cinnamate, levodopa is metabolized in the brain to dopamine. Carbidopa will inhibit the conversion of dopamine into the peripheral tissues. So you have one that's producing or metabolizing the dopamine in the brain, and then the other one is inhibiting it from being converted and lifted and sent out of the tissues of where it needs to be. Other drugs, Recrip or ropinirole is also another drug that's used. It is a dopamine agonist. Helps stimulate the dopamine receptors. Amantadine and anticholinergic. So amantadine, which is Simitrel, there's actually two uses for this. They use the amantadine for Parkinson's disease, but it's actually also very effective for the flu. So if patients start to come down with the flu, they start to take this medication in the first 4 to 8 hours of symptoms. It can significantly shorten the duration and severity of the flu. Benzodropine, which is Cogentin, is used to block the cholinergic effects. So that's what's used to help treat some of those secondary involuntary muscle movements. So COMT inhibitors, these block the enzyme that actually metabolizes dopamine. They also help to boost the effect of levodopa and carbidopa. It also helps to increase the effect of dopamine by allowing the dopamine in the body to remain active longer. Its role in therapy is to help control the symptoms when the levodopa wears off at the end of each dosing interval. So as we take our medications, it's basically what I want to say, like a chart, right? We take the medication, so it starts off very low, and then as we are absorbing it and it's being absorbed and used, it kind of peaks, and then eventually it will taper off, and that's when the next dose is going to be due. MAOIs, they block the monoamine oxidase, which is an enzyme that breaks down the dopamine in the neurons. It's used as an initial therapy to improve symptoms, and again can be added to the levodopa to help to prolong the effects of the levodopa. Myasthenia gravis is a disorder of the interface between the nerves and the muscles, in which the muscles cannot respond to the nerve system or nerve signal in order to contract. So the cause is actually an autoimmune damage to the ACH, which is acetylcholine receptors, at the connection between the nerve and the muscle. Symptoms include paralytic drooping of the upper eyelid, diplopia, which is doubled vision, imperfect articulation of speech, and then difficulty swallowing, which makes sense because all of these areas with our muscle movement, we have muscles in our eyes and our eyelids which help us blink. We get muscles in our mouth, right? Our cheeks, our tongue, to be able to talk. And if those are affected, then we can have those symptoms. So treatments, there's a lot of different treatments, but basically they're working to block the ACH or the acetylcholine. So a lot of these medications for the myasthenia gravis, so Imuron, which is azathioprine, will suppress cell-mediated hypersensitivity and alters the body's antibody production. So when you have an autoimmune response, your immune system is working overtime. Your immune system is kind of turning on itself or turning on a specific organ, and that's what's happening in this case. So you have your own immune system is turning on and damaging the acetylcholine receptors, and then this is the result of that. So we are going to end there, slide 31. If you have any questions, please go ahead and give me a call, send me an email. I'm happy to help.